Digital Jersey and the Health and Social Services Department launched Jersey's first digital health strategy. And that was the culmination of a lot of work between the private sector and the public sector. I think it was a great example of the way we can do things in Jersey. The fact that we can have all the key people sitting around literally the same table, primary care, secondary care, family nursing, government departments, tech companies on and off island. And that project really is looking at setting out our ambitions and our approach to digitising the island's health and care system over the next 10 years. This is a long-term plan. And that strategy sets out a vision for Jersey to have a digitally world-class health and care system that uses technology everywhere. It's a digital-first approach to improve all aspects of care. And equally importantly, to create an environment where innovation in healthcare can flourish. And there's been significant progress already behind the scenes, as well as a bit more front of house. And that's been work done, contracts in place with off-island and on-island companies working together, for example, to integrate the hospital system and the GP system. Now, a lot of people may think, well, that sounds a bit daft, that they're not integrated already, but that's a problem that is everywhere around the world. In fact, what I'm very proud of is these companies that run the systems here, they operate all around the world, but the first place they're going to integrate those systems is in Jersey. And I'm particularly quite proud to go into this Jersey hub and see teams locally and off-island working together to solve this problem. But also, we're looking to see how we can establish an innovation hub within the new hospital. Because I think we have an opportunity there. You combine that innovation hub with our goals of growing the local digital health economy as well. And you look at what we have here. We don't talk enough. We don't talk about, somebody said the other day, how can we have a USP in areas like technology? Well, you go to the UK and you tell them that by February next year, every single broadband connection in Jersey, whether commercial or residential, will be gigabit fibre to the premises, and they don't believe it. Nowhere else has that. Nowhere. And that allows you to combine that with some of the other strengths we talk about, and you'll see us talking about this next year, to create a real sandbox in Jersey, not just a fintech sandbox, but a health sandbox, an IoT sandbox, and watch this space for further developments there. So, but it is extremely important. We don't have all of that expertise here in Jersey. In Jersey, we can look around the world for good examples of how this has been done elsewhere. And so, as a result of that work, and I want to particularly thank here Jason Turner from HSSD, Danny Bannister, and Chris Knight from my team for going out to London, for meeting some of the guys who are coming out here today and putting this day together for us. And I'm delighted to welcome three of the UK's leading pioneers in integrated healthcare technology to come to Jersey today to talk about their experiences, to give us the benefit of their fantastic insights into how they've encouraged digital transformation in the NHS. Now, this morning's speaker, sorry, it's in the script, I've got to say this now, has been referred to, normally by Danny though, and as everyone knows, Danny Bannister never exaggerates things at all, refers to our speaker as a rock star CIO. And I had to look that up the other day before I went on Radio Jersey, because I thought they're bound to ask me about this, what the hell is a rock star CIO? But actually when you look at it and you think, it takes special people to lead technology transformations, to lead any change management process in organisations, particularly organisations that are understandably quite risk averse. We want them to be risk averse to a large extent. And it takes some special people to lead that. And we've got one here today in Andy Kinnear. Andy's Director of Digital Transformation at the NHS and Chair of the British Computer Society's Health and Social Care Group. He's got an outstanding record of leading organisational change and technology-enabled change programmes. And we've seen already how passionate he is about the role digital will play in the future of healthcare. So please join me in welcoming Andy Kinnear.
Thank you. It's nothing like a big build-up, is there? This rock star, woo, hello Jersey. All right, so yeah, good morning everybody. This is my first time on the island. I got here about 6 o'clock yesterday evening. Enjoying it so far. Adrian and I liberated a little bit of your liberation ale from the barrel last night and hope to liberate some substantially more of that later this evening. It's great to just be part of your journey, actually. So We had a pre-meeting ahead of this in London, and talked through where you've got to so far and where you're hoping to get to on your sort of digital jersey ambition, and particularly around your jersey care record. And I've just got to say up front, your story is interesting but not unique. So up and around the world, certainly up and down the UK, people are trying to solve the problems you are solving here. And so if you can, do more of this, engage and understand and learn and share, and critically share the advantages you've got here, because I think you're going to run ahead of lots of places. You've got so much potential that you're going to run ahead of lots of us in the UK. You've not got, ridiculous government dragging you back and things like that will get in the way. And I think, so that big advantage for us is this is a kind of mutual moment. So we're happy to come here and sort of tell you a bit about what we've done, but we're hoping there'll be a lot of the return in the favour in the time ahead. So this is who I am. I continually suffer indigestion because I bite off more than I can chew. I've got a number of roles. A couple of them actually pay me some wages as well. Most don't. So I fulfil a number of things. But I work at local and national level in the NHS. And I'm going to talk today a bit more about some of the work I've done at local level in particular, but try and reference some of the national things that are going on in England at the moment. As you can see there, I'm also support the world's greatest football team, and didn't have anything to do with the Ben Stokes Bristol incident this week, but glad to see you made the Ashes squad. So what I was going to do is just do a bit of national context setting initially, but then really get into the weeds of what a shared care record programme looks like. And what you've got in myself, Amir and Adrian today is a bit of a story of how mature shared records will develop, or how we believe they'll develop. So the story I'm going to tell is largely about how you build trust between organisations and create a place where you've got the beginnings of a shared record, and people are comfortable with the idea of sharing information across different care settings and things like that. So that's the kind of basics. This is how you get these sort of programmes out of the ground. What the future of this world looks like is where you generate genuine open API technology and allow all of this stuff to share, constantly between between native systems and between clinical systems. And that journey is going to take a bit longer for us to do. And the three of us are involved in a program called Interopen that I'll mention, that will describe a little bit about that. And then actually where we get to the real prize, where the real prize exists, is where we're not just doing this for our professional community. So we're not just delivering shared care tech capability for clinicians, nurses, sort of social care professionals and so forth. We're actually doing this for the public, and we're empowering them to take control and manage their own records. So the work Aid will talk about around PHRs will sort of get us into that space. So that's what we're going to cover. So I work for the NHS. We've got a bit of a birthday coming up next year. We'll be 70 years old. I presume you've all heard of it. It's a fairly recognisable brand. It's the 5th biggest employer in the world. I realise we've been overtaken by McDonald's just recently. I think they've had some penetration success in Eastern Europe that's taken their workforce up. But anyway, so it's a big old entity, and it's a big old complex entity made up of thousands of organisations. So one of the biggest contricts in the UK is that people see that logo and they actually believe they're working with one organisation. They're not. They're working with thousands and thousands of organisations, all with different levers, all with different drivers. So it's a really complicated thing to be part of. I've been part of it for 27 years and still don't really understand it, if I'm honest. And then in terms of our sort of digital strategy we're working to, is three really sort of key documents in here. The first one over here, the 5-year forward view, is really the attempt the NHS made to make sense of Andrew Lansley's 2012 reforms. So we went through probably the worst reorganisation most of us have ever gone through, and have lived through the last 5 years, one of the most broken versions of the NHS we've ever been part of. And you can tweet that, because my opinion on Lansley's reforms is fairly public. And the 5-year forward view is an attempt to make sense of it and find a way forward to help deliver the NHS. Personalised health and care is the digital strategy that then underpins that, so it's sort of how are we going to solve that. Both of those documents mention the word interoperability sort of every third sentence. It's really key that they see that joining up information is really important. But the seminal moment, the really key document, is this one on the right-hand side. So it's the colloquially known as the Wachter Review, the Bob Wachter Review. And this gentleman, Bob Wachter, came over to England last year. He's a physician in California, works at University of California Hospital in San Francisco. And he's also the author of this book, The Digital Doctor, which if you've not read, I could really recommend. It's a clinician's perspective on digital, and he talks about the way in which doctors can do as much harm now with a keyboard as they can with a scalpel or with a prescription pad. So it really talks about the way in which digital is changing the way doctors work. And he's come over to England and he's done a review, and it's a game changer for us. It really is. It talks about the adaptive change journey that health needs to go on to really realise the benefits from digital capability. So it's not just about deploying some technology, which is what we tried to do in our national programme for IT back in the sort of early 2000s. It's really about allowing clinicians to reimagine the way they can work within a digital world. It's an absolutely brilliant read, and if you take nothing away from everything else I say, take away the fact that you need to go and get the WACTA report and read through it, because it's incredibly helpful. And what it really says is that actually the NHS has got to face up to its reality, that actually if you're going to be successful and survive in a world where austerity and financial savings are the number one driver in town and have been now for 7 years, then you've got to get on and deliver the IT. So that's the kind of backdrop that we're working to. So I'm just going to focus in on these two roles in particular, and mostly talk about the Connecting Care programme now. So what we've got happening across this is the patch that my digital transformation sort of footprint covers. So a big chunk of southern England. I got a team of about 140 people running digital projects across that geography, and these are the shared care record programmes that are in existence across that piece. So county by county, city by city, folks are working their way through creating or have created shared care records across health and social care domains. Some of those are really mature. I'm not going to say too much about the Hampshire. These guys have been heavily involved in Hampshire right from the beginning, but the Hampshire Health Record, the Hampshire Shared Record, is probably the most mature shared record in the UK. It's been around for over 10 years and has really got a very established footprint. Oxford and the Connected Care programme in Bristol are both up and running, and people are getting them. Most of the others are in development. They're work that are going on at the moment, including the wonderfully titled Cider programme in Somerset. If you know people from Somerset, they're not happy unless their programme's got a comedy name. So it does stand for something legit, but it's a side thing. So let me tell you about the Connecting Care stuff. Let me tell you about this work, and I'm just going to rattle through and tell you the story that's been a big part of my life over the last 6 years or so. So this is the footprint that I'm talking about, known locally as BNSSG, the Bristol, North Somerset and South Gloucestershire. I'll just say Bristol for the sake of argument, but it's a population of about 1 million people in the West Country that we serve. And the Connecting Care programme is our attempt to bring folks together around the table to share information and to improve care by bringing together that combined record. The initial ambition really to deliver a view-only shared record, to just give people that capability when they're in their care setting to be able to see the information that's been collected elsewhere. And so these are the kind of drivers really. And there's sort of local and national, or local and strategic. So there's a whole heap of quotes here. These feel quite aged to me now actually, but they're still quite interesting to read. These are what doctors and nurses were telling us back in about 2011, and they're just frustration really. They're just sheer frustration that day in, day out, they know the information they need on the patient in front of them exists as part of the system, and yet they haven't got it. And so they know the GP's collected it, or they know the social care got, or whatever. You understand the story. So that's the sort of driver that exists at a local level. And at a national level, you've got a couple of major drivers in there. So all of the work that's come out of the Caldecott reviews that talks about our duty to share as well as our duty to care, and drives in there. And then a frightening number now actually of really tragic serious case reviews that have routinely revealed the inability to share information between public agencies has led to harm and has led to care. And of course I'm sure you may or may not be aware, but anyway, the tragic story of Victoria Columbia, a young girl who was neglected and ultimately starved to death by her aunt and uncle who were her foster parents at the time. And you read the Lord Laming report, and it is really clear in there that this was a failure of agencies to share information. Lots and lots of people, social care professionals, health professionals, ED departments, you name it, had been involved in the care of this young girl, and yet nobody had put the whole picture together and understood the story. And at the end of it, you end up with a real tragedy. Winterbourne View is a nursing home in North Bristol. Well, it's in South Gloucestershire actually, but in the North Bristol community. And again, you know, whole history of abuse going on there, lots of clinicians and everybody involved, but nobody capable of putting the whole story together. So these are the kind of drivers. Until we can do this, we can't provide the safest care. So this is the kind of Andrew Lansley's moment in broad manifestation. So these are the 17 health and care organisations that exist in Bristol. So obviously the optimum model to serve a population of 1 million people is to create 17 separate organisations, all with different drivers, levers and motivations to actually serve all of that. So this is, sorry, this is proper complicated dynamics that exist, and actually it's not that clever, in all honesty. And what we're starting to see now is an emergent pattern of merger with organisations come together. But what's on that slide, just to give you an example, is 3 acute hospitals, 3 community providers, 3 local authorities and 3 commissioning organisations, 1 academic research organisation, a mental health trust, an ambulance trust, a commissioning support unit, and I've missed somebody out, an out-of-hours service, that's right. So, you know, who the hell would design a health service like this? Do you know what I mean? It's an absolute crazy mix. But what it means is you've got a lot of complicated vested interests, parties, people coming with different lenses to the table. So it makes for a pretty interesting dynamic, to say the least. And I'm going to try and get to you across the point that part of the success of these programs is about being able to recognise all of those different dynamics, those different lenses that people are looking through, and actually do the people bit. Get the kind of hearts and minds in the right place first. So it doesn't really matter that there's 17 organisations if all of them believe in the same outcome at the end and they all behave in a way that is working towards that outcome, which is what we try and do. So we began our project in 2011, the original vision. The original vision was really one of, is it technically possible to create a joined up shared care record? And if it's technically possible, does anybody find it useful? So it was really quite a simple starting point. A few of us put a few quid on the table to get the project out of the ground, and we kicked off. We spent 2012 in procurement, really wonderful exercise going through the OG procurement process, and signed our contract in February 2013 and went live with the system in December 13. So really rapid once we got past the buying it thing. We started with 500 users in urgent unplanned care, across different care settings, so in hospitals, in GP practices and out of hours, in rapid response teams in health, in community and social care and things like that, but people who are broadly around the urgent care journey. And then we began the business case. So this is a little bit unusual, certainly in NHS terms. Generally the Treasury expects you to write a business case before you actually start spending money and buying software, and certainly before you do a procurement. But in effect what we did is built the working thing, got a pilot version up, got it working out in a real live environment, and then went back to get the money to really make it happen at that point. We had a really smug moment in October 2014 when 5-year forward view was published, because we were already doing it. So what it was asking the country to do, we were already kind of 3 years on our journey, so we had a little went out at a few jollies that night to celebrate the moment that we were on the right strategy. And then really the journey since 2015 has been one of growth. It's about growing the use cases, so more functionality. It's about growing the richness of the record that we've got. It's about growing the number of users that actually access it. It's about growing the number of contributory systems, and it's about kind of, I was going to say growing the dream, but you get it. Sort of growing the momentum, growing the sort of passion, and getting people to really believe in that shared record piece. So this is it. This is a sort of schematic. This is the only sort of technical diagram in this presentation. So for those of you who like technical diagrams, really suck it up and enjoy this little moment. For those of you that can't bear the technical, bear with it. It'll all be over in like a minute. I'll get through this one as quick as possible. This is the architecture that we've built in our Bristol community. And what you've got across the bottom are a whole heap of, in fact this slide is now out of date, I can see it is already actually, it's got slightly more contributing systems than that. But in a sense, a whole set of electronic health records in different environments that are contributing data to the shared record. Most of those come through and up into the CDR. Some of them come, the EMIS and the EMIS community and primary care use a solution called the MIG to bring their data through. And then we've got a lot of jiggery-pokery tech in the middle, so an integration engine. I should say our partner on this project is a company called Orion Health. You may know they're a global systems integrator. They've got serious pedigree. If you're sort of interested in their background, they're a New Zealand company, and they merged out of the Canterbury and Christchurch communities in New Zealand. So lots of sort of seriously mature system integration. If you want to go and read a case study on somebody that really has done it, then go and read the Canterbury story, and particularly around the Christchurch earthquake and the way in which they were able to cope with such a disaster like that, because they actually had an entirely electronic shared record, and therefore the fact that the building that contained all the paper notes had been pretty much destroyed in the earthquake didn't really matter. People were able to carry on. So it's an interesting story, and they're an interesting company to work with. So they got the IE and the repository where we store the data, and then Nextgate are our partner for Master Patient Index. So one of the technologies you need behind a project like this is the ability to join records together, regardless of whether you've got identifiers that match in them. So they're the folks that provide the fuzzy logic that allows us to join a whole heap of social care records in, despite the fact that those folks haven't got a unique NHS number as part of their record. So it's a bit of cleverness in there. And then at the top level, we get into what people see. So what the doctors and the nurses see. So the actual portal itself, the presentation, the screens and things like that, and the security and consent models that sort of underpin it. So that's the thing. All right, breathe. That's the technology bit over. Okay. So the benefits. Where have we got to? Where have we got to on benefits? So I guess we began this program with a real focus on the need to sort of justify the investment that we were seeking. So we did a lot of work in that first year when we were building the system, capturing baselines, so asking people what their jobs were like, measuring time to resolve problems, understanding how much time people were spending on the phone trying to track down bits of information, various things like that, and gathered a whole heap of evidential information that allowed us to make a case, in effect. So, lots and lots of measures. What we also did is gathered an absolute sea, literally thousands of quotes from clinicians and care professionals about what their job was like. So just, a sea of frustration is the only way I can describe it. A whole heap of stories that came out of this. And then when we got to the other side, when we got live with the 500 users, we began to then repeat that journey and start to talk to people about what had changed and what was different and things like that. And these are the kind of sort of things that we started to emerge. These are the themes, I guess. The benefits piece. I've got a 60 slide deck just on benefits alone, if anybody's interested in seeing it any time. But in essence, these are the kind of themes that began to emerge from that journey. And I think they fall into two broad categories, but there's almost a sort of cross-cutting bit as well. So the two categories that they're in are efficiency benefits, first and foremost. So lots and lots, you'll see on there, repeated saves time. So there's just an industry in the NHS of people ringing each other up to get bits of information. There are GP receptionists who spend their entire day on the phone to hospitals just answering questions about patients in their care, and giving over basic bits of information, current medications or whatever it might be. Really, really sort of simple stuff going on like that. Lots of sort of efficiency benefits in there, and there's one there's one I'm going to tell you about as well that's really I really like. So there's the efficiency and kind of financial savings benefits. So this one in here, this saves installation and equipment costs. In social care is quite an interesting one. So I'm walking through City Hall, the sort of City Council building on one day, and their Director of Social Services stopped me and said, "Do you realise your system has saved us £30,000 this year on toilets?" And I said, "All right, that's good," sort of thing like that. I said, "How's it done that?" And he said, "Well, what we're able to do," he said, "is the council, the local authority, have got a duty to go into people's homes and install equipment if they're becoming infirm, or, you know, so with handrails or, you know, slopes to get them up steps, or, you know, what do you call it, stair lift equipment, or downstairs toilets. So they put in a downstairs toilet if somebody's, you know, infirm and needs all of that. And what they were able to do by having access to the shared record, they were actually able to see the real status of this person. You know, the fact that they were likely to be going into a nursing home, or they were in hospital and they'd been there for 6 months, and they, you know, actually installing a downstairs toilet might not be the most high priority thing at this point. In fact, they might not even be coming out at all. And they were sort of changing the way in which they did their work on home installation of equipment. Okay. Now, the reason that's interesting, I think, is that was an unanticipated benefit. So there's no way when we started this project that I thought we were going to save money on toilets. Right? In fact, if somebody told me, I wouldn't have even, you know, I'd have laughed out loud. And we saw a lot of that. We saw lots of people coming forward with benefit that was unperceived, unanticipated. You started to see, you know, sort of stories like that emerging all the time. So that's the kind of efficiency, cost savings type of benefits. The other ones, even more important, I think, are more interesting, and certainly for the clinicians in the room will be more inspiring, is the fact that it was safer care. Hey, he's got his hand up. Why are you interrupting?
I just prefer your story about putting the 24-hour joiners out of business.
Oh yeah, okay, I can tell you. Oh, I could do that one as well. Yeah, I can do that as well. Yes. Well, I'll tell you that. I'll do that one now because that's a safer decision one. So yeah. So the other emerging story in all of this is the fact that clinicians, if you give them more information, they can just make a better decision. So whether that's hospital doctors or GPs or social care professionals and stuff like that, if they've got more information about the person they're trying to deal with in front of them, I'm stating logic here, aren't I? Then they can make a better decision. And actually, the story Ed's referring to is one of our out-of-hours GPs. Tells this tale. He does it far better than me, but I'll do the best I can. Where very often in the middle of the night he's got your patient's not, you know, in distress, or the family's in distress is more likely, and they're in touch, and he's got no information on this person. He has no idea. And in the past, he's got to the point where he's had to ring the police and get the police to go and break down the door of the house to actually get in and check this person's, you know, okay, and do all the things like that. And whereas now he's got all of the information about this person, you know, really rich record in front of him and access and details, and he changes his decisions, and he makes, you know, a different decision as a result of that, which doesn't involve smashing the door down. Of course, when he tells the story, he says that, you know, the only person that's upset about this is the emergency joiner industry in Bristol, who are not going out to repair the doors the next day. But again, it's sort of it's a quite a, you know, strong example of the way in which clinicians can change their behaviours. And actually, again, we went back and got the quotes, and we've got thousands of these. You can have any of them if you're interested, around the way in which the clinicians are sort of describing the way in which having a shared record is changing the way they work and they can access. So we've got a few of those in there. But you can sort of get the point I'm making, actually, that people's jobs are different. There's a great story from pre-op assessment in the hospital. When they began a pre-op assessment previously, time from initiation to completion was about 4.5 hours. That wasn't 4.5 hours solid work, but in terms of ringing the practice, leaving a message, waiting for the GP to ring back, confirm the meds, whatever it was, you know, all of that sort of nonsense that goes on, was about 4.5 hours elapsed time, and broken time where a junior doctor's having to keep coming back to the same case again and again over that 4.5 hours to sort of finish the pre-op. Pre-ops now take about 90 seconds. They do the whole thing online. They generally don't have to ring the GP at all. They can just sit, churn all the way through that. So 4.5 hours down to 90 seconds, you know, you'd take that pretty much any day of the week in terms of benefit. And then, so I'm just going to finish really and talk for sort of 5-10 minutes or so just about the people side of all of this, because if I left Bristol tomorrow, I think the thing I would be most proud of is not necessarily the system or the technology that we've deployed. It's the fact that we managed to get 17 organisations and all of those people to work together on this thing, and all of their suppliers and all of their clinicians and all of that. It's the behaviours and the people thing that I'm kind of most proud of. And I think in many ways in these projects, when you're trying to do them, that is by far and away the hardest part of this. Deploying the tech is just work. It's just turn the handle and get the stuff working. That's not the hardest part. It's getting the people. And so Connecting Care has really been, you know, characterised by these things. Multiple organisations, all with their own drivers. You know, so the hospitals are incentivised to have more people coming through their door because that's how they get paid. and yet the system can't really cope with that. But if we take people out, how are we going to backfill their, you know, their funding? So you've got all of these sort of weird levers going on. You've got loads of clinicians, all of whom are the most important people on the planet, obviously, and have got their own drivers, whether it be in their space or their research agenda or their, you know, whatever it is, but a sort of set of drivers in there. And you've got lots of suppliers, many of whom are bringing complex commercial interests, and some of whom who actually believe creating a shared record is a threat to their business, because they think the shared record should be actually everybody moves to their system. Somebody can tell Frank Hester at TPP that's not what any of the NHS is really going to do, but nevertheless there are definitely some commercial outfits out there who still believe that that's the thing. But underneath it, of course, is one patient who still sees that NHS logo everywhere and thinks that they're dealing with one organisation. And so actually what you have to do in this sort of herding cats challenge, as I describe it, is recognise those elements, so recognise those political dimensions that exist and play them in, understand the personal dynamics that are in play, understand the human behaviours. So when a doctor is standing in front of you and describing the information governance or the information security reasons why he or she can't share their record, they're really saying, I've recorded some stuff in that record that I might not be very proud of, or I've not recorded stuff in that record in a very consistent and professional way. And actually, if I start sharing that, I'm going to be a bit embarrassed by that, and I'm not going to look that clever. So they're telling you one thing, but actually the real dynamic, it takes you a bit of a while to understand this, but the real dynamic behind it is one of embarrassment or whatever, you know, they're little. So it's understanding those kind of human behaviours that exist within these programmes that are part of it, the organisational behaviours, and then getting into that kind of people's individual interests and stuff like that. And I've had situations where you know, finance directors have stood on stage and done a talk like this as if they did all of the work themselves, and I've had colleagues in my team say, how can you stand there and listen to that and stuff like that? And I say, well, that's their personal motivation. They need to be the person that sort of does that. I don't care. As long as they keep signing the cheque and giving us the money to make the thing happen, then that's fine. And so actually the way you get past that, and the way you get past certainly some of those organisational levers, is to remind them why we're here, because we're public servants and we're actually all serving this 1 million people in the city of Bristol. And actually, if you make that your mindset, and if you make that your sort of daily way of thinking, then actually you can actually deliver programmes like this, and you can act bigger than your organisation and bigger than the drivers therein. And actually what I've witnessed with this programme, I think I'm now starting to see in lots of other parts of our lives, and in fact even the fact we're here today is an example of the way this world is working. So we're moving from a situation where sort of top-down hierarchical, you will do this type management was the way you got digital health and care delivered, to a world in which actually it's by networking, and you sort of join a family where everybody has got a shared view of you know, the collective aim that we're trying to achieve to improve, you know, health and care around the world. And you can start to see examples of this, and I'm going to sort of describe a couple of them now, probably in a little way to try and preempt what some of the guys are going to say later on this afternoon into the evening, around just the sort of movement and examples in the way in which this human dynamic is changing around the delivery of digital health and care. And actually in Jersey, you've got every single opportunity. I mean, believe me, it's right there in front of you to go and be hugely successful. But you've also got an opportunity to come be part of this family, be part of this global, you know, thing that's going on. And so I'll give you some examples of the way in which it's changing. So this is one, the CIOs and CCIO networks. So this is a group of folks who had a few pints in a pub 5 or 6 years ago and decided, wouldn't it be a good idea if we networked together as a group to share across the health service the way in which we work. Here we are 5 years later, we've got 1,700 members, are members of the CIO-CCIO network. There's an online discussion forum where there's something like 100 posts on it every single day. The whole thing operates in Chatham House. So 1,700 people are discussing digital health strategy online every single day across England in a very open way. I mean, believe me, if you saw some of the exchanges, Aide's the chair of the CIO network down there above Boris Karloff. I think Joe MacDonald, who's the chair of the CCIO's network. And you know, you see some of the posts, they're pretty damn candid. You know, people aren't holding back on stuff. This is a real honest exchange of issues and things like that. But it's a network. It's not really like anybody's in charge. I mean, Aide's the chair, but he's not really in charge. It's not really like that. It's a big old family of people just sharing stuff. So that's one example. Another one, and I'm sure Amir will touch on this when he talks later, is interopen. So this is what you call it really, it's a club. It's a whole group of people who want to develop the open API standards to support better information sharing. The members of this are NHS organisations, are national bodies, NHS Digital, are 120 plus private companies, software companies are all members of this. All of the kind of technical bodies that design APIs are members of this. It's just a big old club of people who want to develop open interfaces to join information together. It's a really strange dynamic. It's very different to that kind of top-down hierarchical thing that you might be used to in that space. And then it gets even weirder. So you get into sort of Data Saves Lives campaign. Don't know how many people recognise that hashtag and see all of this. But this has been driven out of the academic community. So there's Professor Ian Buchan in the top right there from Manchester University and the FAR Institute. And they're really sort of driving this idea that actually you can do more harm with data than you probably can with a prescription pad these days. And so actually, and they evidence it because they're academics, that's what they do. They research and they write it up. And so there's a huge campaign that exists. And I mean, there's nothing to stop you. You just join the club. You just get on Twitter and you start hashtagging your tweets and you're in. There's no barrier to entry to be part of this, part of this dialogue and this. And then this is the weirdest one of all. So I'm wearing my pink socks. You've got yours on. Aids are in the wash. Can you believe it? He came to Jersey and he's told me his pink socks. So I got my pink socks on today. Amir's got his on. This is the weirdest club ever, right? So this guy down here, Nick Adkins. He is a fully 100% Californian hippie of the greatest type. Real believer in love, peace, and harmony. And he gave a speech at a conference a few years ago where he wore a kilt a friend of his had made. And he wore a pair of these pink socks. And he gave an inspiring speech about if we just, and this is particularly poignant in America where, it's a very voracious healthcare system, largely profit driven. You bear in mind they're spending double what the UK spends on health and they've still got a third of their population barely got any health cover. So, they ain't quite got it right over there. But he talked about if we just loved each other a bit more and feared failure less, went for it, and just, did it all with hugs and love and caring as a human race, then we could actually be in a better place. And the way out of that, this pink socks tribe emerged, and he starts awarding people who are showing the right behaviours, who are loving their fellow human man in the right way. You get awarded a pair of socks. So I go over to Ireland in, when was that? May, earlier this year, and Richard Corbridge, CIO of Ireland, presents me with a pair of pink socks, and I'm suddenly in this tribe. And before you know it, I've got 10 pairs of socks in my house, and I'm handing them out to folks. Amir walks around with about 200 in his bag at any one moment, and he's continually awarding people he feels are doing the right behaviours with a pair of socks. It's proper weird. I mean, it's proper strange. But actually what's happened is there is a group of folks around the world who are now pals or members of this thing and are sharing the way in which we are delivering and doing digital health and care. So it's odd. It's not like anything you'd ever sort of see or normally recognise, but it's good fun. So I find myself on the phone a couple of weeks ago to Dan Northman in New York, having a conversation about autoimmune software he's developed for the autoimmune industry that's now on its way to Bristol. That wouldn't have happened without this. It's a sort of network connection thing that's going on. Believe me, if you start following it on Twitter, you'll think, Christ, why was he saying that? It's the most surreal. Some of it is proper surreal, and you really have got to get in touch with your Californian hippie side. But that's what's going on. And so when I do this talk and talk to some of my staff, I just finish it by really saying, look, how lucky are we? You think about the people. There's some people who get up and go to, everybody who gets up and goes to work today, each day, and what they have to do, what some people have to do in their jobs, the kind of jobs they get to go to work to do. And so I always finish with this because I like people to just remind that what we get to do is a real privilege. How lucky are we to work in the digital health and care space? Because we get to have an impact on this and on that and on this, these and on that. And actually, I think the real takeaway is to truly enjoy what you're doing. Because if you work in digital health and care, you're doing something good for society and you're doing something good for your fellow man. So go out there, be good for the people of Jersey, enjoy yourselves, and hope you found that useful. Thank you.